Good evening and welcome to the third ELETS Healthcare Transformation Summit. We are now heading into a panel discussion on can open source technology be the solution to accelerate digital healthcare in India? We are delighted to welcome Dr. Praveen Gedam, Additional CEO NHA, Ms. Sunita Nadamuni, Head Social Innovation Dell Technologies. Welcome, ma'am. Mr. Sohail Bidani, Lead Digital Bill and Melinda Gates Foundation. Welcome, sir. Dr. Manju Sengar, Professor, Medical Oncology, Tata Memorial Hospital, Mumbai. Welcome, ma'am. Professor Ganesh Ramakrishnan, Institute Chair, Professor, Department of CSE, IIT Bombay. Welcome, sir. And Ms. Ruchika Bhargava, Market Delivery Partner, ThoughtWorks India, who will be the session chair for this session. I now hand over the session to Ruchika Bhargava to take the discussion forward. Over to you, Ruchika.
Thank you, Garima, for welcoming us, and good evening, everyone joining us today on this forum. Thank you so much for investing time to be here, and thanks to our panelists for taking time from their busy schedules, as well as the Elites team for providing us this forum. My name is Ruchika. I am a market delivery partner working with ThoughtWorks Technologies and will be the session moderator for today. And what do we have today? We have an amazing panel on can open source technology be the solution to accelerate digital healthcare in India, where we will be talking about as Indian healthcare looks at digitization, how can open source software help facilities hospitals to take that leap forward, and how as you healthcare experts, industry partners, technologists, and even students can contribute, assist in this adoption and spread this awareness. Now, talking about open innovation, is it a new phenomenon? Definitely not. Even the first Oxford English dictionary was an open source project. That comes as a bit of surprise to a lot of us, right? So let me first talk about the format of what to expect in the next 1 hour. We will be starting off with a brief introduction about our panelists. We will hear a welcome note from Dr. Praveen Gadam, additional CEO of National Authority. Then I will be kicking off the conversation, asking questions that draw out on some high-level themes about the relevance of open source technologies in healthcare, the contribution areas as well. Last 10 minutes, we will be opening the floor for any questions that you have in mind and taking the discussion forward from there. I hope that sounds good. I'll kick off by introducing Mr. Sohail Bidani. He is the lead for the digital technology work in the India office of the Bill and Melinda Gates Foundation. In his role, he has played responsibility of digital and technology interventions across the foundation's programmatic works, and he has over 20 years plus of professional career experience extensively in business and technology advisory across 25 plus countries. Welcome, Mr. Sohail. We also have Dr. Manju joining us today. She's Professor Medical Oncology, Tata Memorial Center, Mumbai. She's also the core group member of NCG, a network of 230 plus cancer centers, research organizations, and patient groups. She also has several publications under her name. Welcome, Dr. Manju. We are also delighted to have Ms. Sunita joining us. She is head of social innovation at Dell Technologies. She also has 2 decades of experience driving the use of technology to enable digital inclusion and transforming life. We will be hearing more from her about the experience partnering with Indian government and working on national NCD program as well. Welcome, Ms. Sunita. Uh, Also welcoming Professor Ganesh over here. He's currently serving as the Institute Chair Professor at the Department of Computer Science and Engineering, IIT Bombay. His area of research includes human assisted AI ML and also AI ML in resource constrained environments. He is also a recipient of many prestigious awards as well. Welcome to the forum, Professor Ganesh. I will let Elit's team go forward and play the video from Dr. Praveen Gadam, please.
Namaskar. I extend a warm welcome to all the esteemed participants of the third Healthcare Transformation Summit. India is witnessing rapid developments in the digital health space. The use and scale up of digital health solutions can revolutionize how citizens achieve higher standards of health and achieve services to promote and protect their health and well-being. Ayushman Bharat Digital Mission is a flagship initiative of government to bridge the existing gap among different stakeholders and transform the digital health ecosystem of our country. Since the launch of ABDM, Ayushman Bharat Health Accounts or ABHA have been created, which now number more than 16 crore. Doctors and healthcare facilities from different systems of medicine are also becoming actively a part of this ecosystem. In this context, I would like to highlight that the use of open source technologies has been instrumental in adoption of several digital initiatives. Building blocks of a national digital infrastructure such as Aadhaar, etc., have also used open source technologies to build their platforms. Open source solutions not only bring down the costs but also foster greater innovation through wider collaboration. Users can customize and modify solutions as per their needs. Bamni is one such example of open source EMR and HMIS systems. Our nation is poised to leverage digital health solutions for public welfare. Let us join hands to accelerate digital healthcare in India through open source technologies, which is inclusive and accessible to all. I look forward to the panel discussion today and give my best wishes. Thank you.
Thank you so much. Thanks extended to Dr. Praveen for his encouraging words. And I welcome first and foremost Dr. Manju to share some light on open source technologies and the work done for Project ECA. And we would be glad to know what was the motivation to start Project ECA in the open source and especially for Indian context.
Thanks, Ruchika. Thanks, the organizers for having me here and bringing forward the steps which were taken by National Cancer Grid. So, just to highlight, Project ECA basically was meant to showcase whether the patient health records can be linked, irrespective of the type of records, whether we are talking of clinical records, reports, radiology images, any kind of record. The reason for that is that we all know, means I'm an oncologist and treat hematological cancers, but if we look at any cancer management, it's multidisciplinary. The treatment consists of certain investigations to establish the diagnosis, investigations to stage the disease, and then you have surgery, radiation, chemotherapy, and towards the end even the palliative care. What happens that except for certain hospitals where you have all these facilities and patients can stay to continue treatment at that particular hospital, most of the times the part of treatment or part of the investigations are done in one place and then the patient moves to another place. And this happens for multiple times, and if unfortunately there is recurrence, the same cycle is repeated, and again they may visit another oncologist or another center. In all this, when a patient moves from center X to center Y, it's the patient's responsibility to carry all the records to ensure that he could give a snapshot of what has happened till now for the disease, what all management, what all investigations have happened to allow the next oncologist to deliver the best care possible. We know that some of us, treat patients who are from the lower socioeconomic status, who do not probably realize the relevance of each and every investigation, and those investigations are missed or the treatment details are not available with them. It results in repetition of those tests and sometimes missing on certain crucial information which is going to decide the type of management. So we realize it's very, very important that instead of having the patient, all the responsibility of carrying the records, producing it in a temporal order, can we link health records across, entire treatment lifespan for that particular patient, and the doctors at next center or the healthcare providers at the next center can access that information just seeking the patient's consent and requesting the center from where the first investigations were done. And the most important thing is the temporality of entire treatment plan or investigations what have happened, because otherwise it requires a lot of duplication of effort even from the healthcare providers to have that story in an order to be able to decide the treatment plan. So that was the whole idea of starting this Project Eka. It was using the dummy patient data set, because we knew that there is going to be consent issues, and unless we are sure that the consent is taken properly and it's well protected, we cannot use the actual patient data set. So we decided to have dummy data set, and it was between 3 centers, with ThoughtWorks being the technology partner and iceberg giving the expert inputs regarding the entire process. So that was Project Eka, and we were very clear that it has to be an open source exercise, so that next person can build the entire future exercise or their own health record linking, if they are going to do it on this platform. And in fact, we are happy to realize that a lot of this work has gone into the National Digital Health Mission in terms of how the subsequent steps were taken. And something which we started in 2019 just as a thought, because we were frustrated on our own, having to face this, because patients come to our center from different cities and states in India, and subsequently they go back and again keep coming back. So this was our own reasons for starting something like this. But then we were really happy to see that it could provide a small stepping stone for the National Digital Health Mission. So that is all Project Eka is all about.
Thank you so much, Dr. Manju, for sharing that. Being that courageous first early adopters and that forward thinking that really brought things forward, thinking of patient first, thinking of continuity of care. And definitely this has become the foundation blocks for ABDM and getting us there. I'll go to next to ask Mr. Sohail actually, why are open source technologies important to accelerate digitalization in healthcare?
Okay. I mean, 3 simple reasons in my view. I'm sure there'll be many more that other panelists can add as well. One, there is a clear opportunity to have efficiency gains and cost savings, which whether it's governments, donors, development partners, or even communities, right? Just coming together, working on something would really help in terms of getting those gains. There's also an opportunity where we are able to allow an ecosystem to really innovate, and I think for me personally, that's the real gain, because the moment we open it up for the ecosystem to really innovate and layer it with multiple services on top of it, uh, you will see far more utility and use cases that will emerge, which also would be interestingly on different business models itself. So that for me is the biggest opportunity per se. I think from a healthcare perspective, and this is my personal viewpoint, we've really struggled to get something tangible out there, which would truly be called a digital public good, for example. And one of the challenges for that has been that, in spite of a lot of money being put in, funding going into the potential opportunities around open source systems, digital public goods, some of the other factors that have been relevant have not yet taken off. For example, how do you create market opportunities for these solutions that will come up? How do you build ecosystems around open source solutions that exist, or any digital public good? These are extremely critical, but this being part of the learning, so nothing to complain. It's part of the learning and the process we all go through. I'm sure we can address these things together. I am more optimistic now than I was in the past on open source systems and the potential of it. Thank you.
Thank you, Mr. Sohail. And I'm glad you actually brought up digital public goods as well. We'll touch a bit on it as well. But I'll extend the question to Ms. Sunita as well. Knowing your thoughts on open source technologies and healthcare digitization, as well as working on government programs, why open source is so very necessary.
Yeah. No, picking up from where Suhail, left off. So I fully agree that, the overall if you look in the government healthcare space, the investment is not enough to really get robust health tech systems. Right? The overall government spend on health is 1.35% of the GDP. And obviously, most of that will go to the more critical needs of HR infrastructure, brick and mortar infrastructure, and facilities and equipment and stuff. So we would, the investment that is needed for digital transformation of the different programs, the different vertical programs, is while it's all happening, it's not enough to keep up in pace with the need for these systems, right? And so there are gaps, and I think open source can really be a powerful way to address those. And what from our experience itself, when we're working with government on these different programs, we've interacted with a lot of the other programs. We're working on NCD, but we interact with a lot of the other programs, and there is so much integration that needs to happen. There are a lot of modules that are common across each of these programs, and there's not enough sharing. There is so much fragmentation. And I think that if there was a more, and I'm very, very optimistic and hopeful about ABDM, and we're just beginning to on that journey. But I think that that is what is really needed, right? We need a much more cohesive action under a an open source approach, so that there can be more sharing, there can be more for instance, the health ID integration that we did with ABDM. We had to go through that experience, like Bamni did the entire thing. But when we did that, we realized that some of the other health programs in the ministry hadn't yet done that. And so we made ours, those particular modules were open source, and we've been sharing that with the other programs. And like that, if that could be done across the board, I think we would see tremendous gains. So to me, I think that the sharing, especially in the government sector, because there's so much commonality in the way the programs are structured and the way the users are using it, there's tremendous advantages of having open source software.
Very rightly said, Ms. Sunita. Keeping like the lower cost of ownership, natively interoperable systems, that is like the need of the hour as well. I'll now ask Professor Ganesh actually. So, how do you see Indian academic institutions contributing to such open source software, and comparing with other countries as well, right? Like US, etc., where things are backed up by industries. You see lot of open source technologies coming into like DHIS, etc. What are your thoughts on that?
Thanks for this question. I see any technology intervention to be of one of three types. Technology interventions could be complementary, could be supplementary, or substitutional. Something like ABDM, the Ayushman Bharat Digital Mission, has tried to revolutionize the entire process of digital health. This is substitutional. Now, Indian academia probably doesn't have today the wherewithal, the strength, and the traction to be able to do anything substitutional. Indian academia is good for complementary interventions. For example, helping we can host competitions for certain best practice based software that can plug into the Ayushman Bharat Digital Mission. The other thing that academia can do is supplementary. Now, I distinguish complementary and supplementary slightly. Complementary, for example, the work IIT Bombay we are trying to do with Bamni. Bamni has offered lots of plug points. You could extend it with speech transcription. You could extend it with optical character recognition. That would be complementary. Whereas supplementary would be creating maybe lower footprint EMR, EHR systems, right? So I would say we need to identify technology interventions along all these lines and identify our strength. And so I think the Indian Academy strength today is more for the complementary and supplementary than create an overhaul in terms of substitution. May not be required in the healthcare space, especially given the recent initiative from the ABDM. I also want to very clearly talk about different kinds of software. This is bookish knowledge, but software could be closed, where the standard is owned by, say, a company and is kept secret. I mean, Skype communication protocol is an example of that. Disclosed. All of us deal with Adobe PDF. We compile LaTeX into PDF. We compile Word into PDF. Why? Because the standard, while it's owned by the company Adobe, is being made available to other companies and users. A third is concerted. There's a consultation on a new standard, and that's very much happening with ABDM. There's consultation on standards, the interoperability, for example, the DICOM standard for images. So that while that has been there for images, there's still a need for getting to standards for pathology. Can we have concerted efforts? Like Java programming language came out of a lot of consultation. The admission to the consultation process, the management of the process, which could be controlled by a company. I think the academia can play a very important role in the concerted effort. And also, to some extent, the previous, when I talk about the Adobe PDF, for example, where some standard is disclosed, there academia can play a role. Fourth, which is open concerted. There's an open participation in the process through which the standard is defined and managed. I mean, the World Wide Web Consortium, an example, HTML is an example. I would say Ayushman Bharat Digital Mission, the plug points that it has created is really open concerted. So while academia can play a good role in handholding training on the open concerted, the fourth, which is more related with the entire substitutional paradigm, that focus could be more of training and teaching and understanding, whereas the disclosed and concerted, where you adhere to existing standards, where your participation is sought, consultation is sought in creation of new standards, these are places where academia can play a critical role. Since I work in the area of machine learning, I can give this example. I think academia can play a critical role in defining standards, helping evolve standards for where humans and machines should interact, right? Especially in the, I gave this example of optical character recognition or speech recognition. There could be translation, helping identify the way, the protocol through which mistakes, errors can be flagged and corrections be made using machine learning paradigms in a way that helps the software have high fidelity input. So thanks for that question.
Thank you, Professor Ganesh. I think that was quite insightful. I'll move on from looking at the current landscape to a bit of more sustainability adoption and how on the ground things go on. So I'll go to Ms. Sunita to ask a bit about the national NCD program. How has technology helped them here, and what was Dell's role as well in the entire program?
Thank you. So the Ministry of Health and Family Welfare, they launched the Ayushman Bharat Health and Wellness Centers, which is one of the pillars under Ayushman Bharat. And that was primarily to move from this more very segmented approach towards health service delivery, where there were a bunch of vertical programs, to a more comprehensive approach, right? And as a part of this, there was the population-based screening and management of 5 NCDs: hypertension, diabetes, and 3 cancers: oral, breast, and cervical. However, like with every other program, there are challenges in running these, in implementing these programs, like human resource shortfall, capacities of health workers, multiple health priorities, and poor utilization of public health facilities. So all of these, they knew upfront that these would be challenges, and of course, the poor health-seeking behavior of individuals. So upfront, it was decided that technology can serve as an enabler for solving these problems. And Dell Technologies had been involved in engaging, we've been working in the public healthcare space since 2013, started working with Karuna Trust and looking at comprehensive primary healthcare, how technology could enable comprehensive primary healthcare. And this was all a part of our Transforming Lives goals towards using, technology, leveraging technology for social impact. And as we continued working with Andhra and Telangana in 2017, along with Tata Trust, in 2018, we started partnering with Government of India on this Ayushman Bharat population-based screening initiative. Basically, what we're trying to do here is look at the entire screening, system, starting from the village level health worker who does enrollment and population enumeration and risk assessment at the house of the individuals in the villages. And then it goes to screening at the health center, and then diagnosis, treatment at the primary health center, with referrals to higher levels for cancers, right? So this entire system, which is run by a army of health workers, you have more than 1 million ASHA workers, you have 200 to 300,000 ANMs and CHOs. So, and then of course, doctors at the primary, secondary level, administrators. So all of this, of course, constitutes the health system. And so we looked, at what could be a technology platform that could enable digital transformation of this entire system. So we developed apps for each level, right? And all of this is sitting on one common platform. And we have a unique ID for every individual who's enrolled in the system. And there's a health record for individuals. So as the patient goes through their journey from enrollment, risk assessment, to diagnosis, treatment, and then back to the lower levels for follow-up. And this, because NCDs are chronic, this will go over their entire lifetime. The idea is that can you have a single health record, kind of like what Dr. Manju was talking about, right? One health record, one health ID for that individual that sits on the cloud, so that as they go back through different facilities, touch point into their system, that health record keeps getting updated. So when the patient walks into a facility, the doctor can pull up that record and then update it. And then obviously all the productivity gains that you get with technology, you can get alerts, reminders, so the health worker knows which person she needs to follow up with when, who has missed their last follow up, whose hypertension is not under control. So that's the whole idea of a platform like this. And this was done as a part of the Government of India protocol. So we worked with the ministry, with NHSRC, AIMS, WHO, ICMR, all of these institutions together who guided on the protocols and the guidelines to make sure it's fully compliant. This is again open source as per MATI guidelines. And this is running in the government data center, in the government cloud. So today we have about 135 million people who've been enrolled in this system, and which is a really significant achievement, because this is a very large public health program, and about 94,000 people trained in 32 states and 590 districts. So it's a large scale program, and we've just begun over the last 6 months. Last year we started integration with the ABDM, with the health ID, and that's been rolled out now in a bunch of states, and we're looking to the next milestones. So basically I think that from our practical experience of working with government on this large scale program, we really believe, become much more convinced and passionate that open source is absolutely the way to go, because the scale of the problem, the diversity of the country, the needs that are there requires that you need a lot, you need that kind of diversity of engagement. So for people to be able to build apps that are suited to specific contexts. So if you go with a platform approach, have open APIs, have interfaces that are published, and then allow for innovation at the application level, I think that's the only chance we have for addressing these kind of very complex problems. So.
Thank you. Thank you so much for sharing, and congratulations on the milestone and the impact that you're bringing to the country. I think that's significant over here. I'll also talk a bit in terms of this entire adoptions and the technology software that we talk about. One of the feedbacks we do here, right, is we need some functional system. And when we get to bottom of what is a functional system, we realize that the technology should not be a blocker or an overhead for the doctors, and it should be an enabler, right? So I'll ask Dr. Manju here, right? What do you see? Is tech being an enabler or a motivator or a blocker here? How to make it more and more adopt the EMRs and EHRs?
Thanks, Ruchika. A lot of us who became doctors, they had a fear for technology and they had fear for mathematics. So that's the reason why we moved away and we became doctors. That's most of us, not everyone. There are some who love technology really, and they love mathematics, and they're playing their love in form of statistics. So the biggest challenge, if you look at, in terms of adoption of EMR from a clinician's point of view, is the time. So if you look at most of the busy hospitals, many times we spend not more than 2 or 3 minutes on a follow-up with a patient, and when it's a new patient, at best it's 10-15 minutes. And just imagine, instead of having a face-to-face conversation trying to elicit the next question based on their response, my intention is to just fill up some fields on the electronic medical record, and my entire attention instead of patient is on the computer. So that, little time what we have with the patient, which itself was a biggest threat between the doctor-patient relationship in India with all the distrust coming in and not paying attention, that this adds another layer of complexity there. And you're just focusing on the computer, and you're not eliciting one after the other question. You're just trying to fill those boxes in your electronic medical record. If you have a synoptic form, which says, okay, this is the first symptom, this is the duration, you don't elaborate on that symptom. You ask the next symptom because there's next row which asks for next symptom. It doesn't allow you to elaborate. So that's how we've been trained. So we've been trained in our MBBS or an MD or later on, that it's a story which you have to begin with the patient, and you just keep on adding some question and you build up on that story. So somehow EMR has failed to capture that essence of doctor-patient relationship. And the second problem is the time taken. All of us are not, most of us have a good typing speed, and so many times you struggle to even fill in those gaps, and then you have mistakes, or you try to cut short because you know that you have 15 more people waiting for you, so you have to just cut this short and move on to the next. So these are some of the challenges which hospitals face, which are busy hospitals. And same way, when you next time, so let's say even if somebody has put in this effort at first visit, at the second visit when the patient comes back, again you don't get the story. What you get is only an output based on the boxes which you have filled, and in turn you again go back and you start asking those things, and there is no what you call flow from the history to investigation. For each one you have to go on to a different button and then open it and see it. So it somehow clashes with the way our mind has been made to think versus what you're doing in electronic medical record. So having said that, if there was a way which could allow this transition, in the sense that whatever is being spoken, discussed, gets captured on the electronic medical record. And I must tell you, dictaphone is not an option for hospitals like us, because you have 20 people, or I'm sure people who have seen me, there are like 5 people have walked in till now as I'm speaking. So the same story happens in the OPDs. So if you say dictaphone, I guess the dictaphone will get thoroughly confused if it is in a busy OPD, that who's talking what. So we have to have a different solution. I don't know that goes to all of you to figure out what would be that solution. And at the same time, that story remains, that patient-doctor contact remains. Then I think the adoption will be much better. And same way, the output should also come out in the same manner. And the temporality needs to be maintained. You don't have to click from one field to other field to get what information you want. It should be just like how our clinical notes, the good old clinical notes used to be. If we get the same kind of pattern, that will be really, really helpful, because otherwise it's detrimental. If you ask me, I would love to have each and every encounter documented on electronic medical record, because when I go back and want to look at, let's say, how my last 100 patients with X disease did, if it is all in the paper records, it's a struggle. You get only 50% of data. If you have it in electronic medical records, you get to know what you're doing and how you're faring in that. But at the same time, the effort needed to do that is too much, and you compromise on that little time which you have with the patient. So if you are able to manage this, I'm 100% sure doctors are all going to be open for EMR, because it's just that how they are functioning needs to be just moved into a digital or an electronic platform. So that's one. But having said that, it's definitely the way forward. We can no longer remain on paper and think that things will function. But I think we have to have some compromise somewhere, in which we, the way we are trained is maintained as we move ahead. So this is all from my side. And another challenge is, though we know there is network, there is, hospital intranet and all that, but there are days when your EMR crashes and then you are neither here nor there, and then everything is stuck. So if we are moving towards the digitalization, we need to have the rest of the infrastructure also escalated or built up to match that need, rather than just sitting and not able to function at all because you don't have your electronic medical records available. So that's about from a clinician to you.
Thank you, Dr. Manju. I think a lot of technologists in this group are hearing you, and I just want to take a moment to mention about an open source project which was funded by Ekstep, and ThoughtWorks team did work on it, called Vakyansh, which is open source project for automatic speech recognition and speech text to speech in Indian languages. And we had done a little POC as well, combining to look at like for with an EMR like Bamni, how do things look like? Can we make life easier? And I also see Professor Ganesh nodding his head. He's also going to play back to his students to get creative, get innovative there. So thank you so much. I'll go to Mr. Sohail, right? We have heard about this, and I think to have open source technologies, we definitely need funding. So what is your perspective around like getting this sustain a long-term community, a free software to sustain, right? How do we go about getting those right funds?
Yeah, first of all, sorry, I'm going to catch that term which you just mentioned. I think there's this big myth that a lot of people carry: open source is equal to free. We need to get rid of that somehow, because there's obviously, the fact remains that any system, any platform, product requires it to be managed. It's a living organism, right? So somebody needs to keep it evolved. If Dr. Manju is saying dictaphone is not going to work, somebody needs to help develop something else which will work, right? All that has to be plugged in. And yes, it requires funding. We are trying to address market failures. We are trying to reduce fragmentations using open source systems. We certainly require that level of funding. Now, the key question is, where do you get that funding from? I think there are two, three aspects here that we need to consider. One, anything which is meant for social sector, larger societal purpose, there is a role that I believe governments have. Just like any other utility, digital today needs to be looked at as a utility. If the government is responding to providing basic requirements of electricity, water at a certain price point, or at least lower slab base for low usage, put it at X, and maybe a multiplier of that X for higher usage. All that needs to be come into play in the context of open source systems or digital public goods. If I have to just apply the same logic, you have a minimum viable product that you would want to offer, which is free or highly subsidized, and then you allow bundling of services on top of it. That will allow the market to innovate, allow for certain money to be plowed back into managing the platform and the product and the systems. Uh, but there'll still be a requirement for some base funding and base support that, in my view, should come from government. Plus, if there is uh, greater interest and applicability for that, potentially the development sector ecosystem could come in, donors could come in, and that happens today, right? You have fairly large global platforms like DHIS2 available, which are funded by multiple organizations coming together, because we see that as a utility tool which could be serving multiple, a very large part of the population globally, especially LMICs. So that's one part of it. From a context of philanthropists, and I'm just talking about individuals, I'm not going to corporate CSI initiatives. I think that's great and should continue. But another element here is to bring in the philanthropists for the same purpose, because they provide longevity in terms of that support. The challenge with donor funding is it can disappear any day, right? So tomorrow your strategy changes as a funding organization, you carry that risk. With Indian philanthropists, because they believe in something, they have pledged their wealth for a certain purpose. I think they bring the longevity to that extent, and that for me is a great opportunity, including in India, not just globally. I'm being very specific, in India as well, where a lot of philanthropists are really wanting to do something on the digital side of things, especially on touch points with social sector. So we need to tap all these different ways, but I cannot agree more. You need stability and at least that base funding to continue managing and evolving the core platform.
Sure. Thank you. Thank you for your thoughts, Mr. Sohail. And I'll go to Professor Ganesh at this moment to ask, like, you heard the challenges, you heard about the impact, and how do you see then from an academic side, what support structure to build for future, build to make things work would you need, and do you seek help from private sector? What are you looking forward to?
Uh, Thanks for that very nice follow-up question. um, we have to realize that we are talking about interdisciplinary work here, right? Dr. Manju Singha talked about the need for something, an alternative that is more robust than dictaphones, given interference between multiple voice channels. Now, it'll be great to have interns, right? Her interns work closely with our technology team, AI team. But then, what unfortunately the impression that sponsoring agencies carry is that interns come for cheap, right? I think the level of respect for interns has to really grow in academia. So, academia are hotbeds of interdisciplinary research and exploration. I think that's a very key um, uh, strength that academia can bring, and that's how they have been thriving. That's how they have been also complementing the industry, the healthcare ecosystem in other countries. So sponsoring such interdisciplinary work is very important. um, it's not that I have a solution, show me the problem, whether the problem and the solution evolve together. I'm very glad to talk about the Koita Center for Digital Health, thanks to a generous contribution from Mr. Rizwan Koita and his wife Rekha Koita, our own alumni. I think it was very nice that they came up with this concept of digital health ecosystem. It's the first of its kind in India, and this is an example of sponsoring interdisciplinary work. And by its genesis, the Center for Digital Health, which I'm currently heading, by its genesis, there has to be academic partnership with hospitals. I mean, it cannot be academia working in a silo, right? Not that I have a solution, show me the problem. um, so this, I would say, is the point number one: sponsoring such work. And I think a lot more people are required, a lot more such initiatives are required to strengthen, at both I would say, at engineering as well as at healthcare research organizations. The second point, where I think the industry can help, besides sponsoring such work generously and patiently, is also being good mentors. uh, if for an academia to understand what is complementary or supplementary, going back to my earlier jargon, it'll be nice to for the academia to know from the industry as well as from the government organizations what really would be complementary. What are the best software development practices, right? We can develop prototypes. How can we make sure that the prototypes are based on standards? And one problem that we, when you say open source, security often just goes for a toss completely, right? So there has to be, for it to be taken to the next level, there has to be the protocol for communication should be secure, right? So software, that's another element of best practices. um, Adoption would be another very important thing. At IIT Bombay, we've been developing in collaboration with with our colleagues. We have developed a platform for um, data efficient machine learning. How can machine learning be done in a very data efficient manner in resource constrained environment? And we're very happy to see that several big organizations saw the strength in that and started collaborating, started using it. It's an open source platform, decile.org. It's open source. But because of the traction that we have been getting, we are able to improve on the software. We are able to improve on lots of libraries that it has to offer. It has at least 5 different components to it. So adoption is another very important thing. Now adoption might also require co-opting interns or consultants. That's possible. But whatever is required towards adoption, the optical character recognition, I gave an example earlier, and that very much complements the work that you were mentioning earlier with Xstep, right? Which was about ASR. Then optical character recognition, we built post-editing ecosystem, not just the OCR, but how to take it to the logical conclusion when it's about digital records. A lot of ongoing work we have with hospitals, including Narayana Healthcare. Now, when we want to close the loop there, it really helps when companies step up and provide consultation on what are the loose ends in such software development. I'm grateful to Geo. I think they've been very helpful. Not only hosted, our services, machine learning services, but they also helped upgrade the thoroughness with which we were building our open source software. So I'm very nice precedents, which I'm very very happy to share. But I think this just needs to multiply. The entire ecosystem of engineers coming together with doctors, coming together with researchers, and we need to close that triangle well. And I think academia can be a very strong driving point there.
I think this was like fantastic and so motivational to actually hear. And thanks for sharing those success stories as well. I think we need to hear more of those as well and take the journeys forward. I think another aspect, I think last few questions, moving on to Ms. Sunita, asking about how and where do you see like some of the advanced technologies that can help in public health? Are there some examples you have seen, anything forward looking you have seen?
Yeah, actually, a couple of the things that I wanted to talk about were already mentioned here, so I'll move on to some other ones. I mean, definitely, I think speech to text (ASR) is important because we see that problem all the time. At the primary health centers, the doctors don't want to sit and enter anything, even if it's very very simple. You make it the simplest of mobile apps, it's still a problem for them to be able to, when they're dealing, they have to see 100 patients in 3 hours is just not enough time to be able to enter stuff. So I think getting robust, and we've tried out multiple versions, open source versions, because we didn't want the data to be sitting on some proprietary cloud. But the open source version, just the quality wasn't good enough. So Vakyansh is something that also we are exploring, and we have to try it out in the field to see how effectively it will work. That's one. Another couple that we, from our experience, training, learning of people, of the health workers, and health staff, right, is a really really important part. And it's hard when you're trying to do it at large scale. So we're still following the age old methods. There is like a training of trainers, master trainers, then that goes down, cascade training goes to the next level and the next level. That's important. I'm not saying you can completely do away with that, but you need to supplement it with more. Today with all the technology that we have, we should be looking at short training bites, right? Instead of doing one massive 3-day training, you get everybody into a room and then you train them. It should be short training bites, short features. It should be built in. There should be assessments and quizzes. It should be personalized. There should be some gamification, certification. There should be nudges, leaderboards, local language stuff. So there can be a lot that can be done in the space specifically for public health, for these government programs, right? I feel that is a whole area that is relatively untouched, and there's so much potential, because really you can develop the coolest of stuff, but if you don't have mechanisms to actually engage the users all the way to the ground, then you're losing that opportunity. So that's one big area. The second area is the whole registries, right? We have registries for health workers, for doctors, for and with all of these, again, we have registries that one program would have used it, we pick up that same list and we use it in another program, and those are so static compared to what's actually on the ground, right? A&M will move to another village, somebody's pregnant, so another person will take her place for some time, she gets transferred to another place. This whole dynamic thing, we don't have a single source of truth. It's changed in different places. So I think that even exploring things like blockchain based registries, some way that we can make it verifiable, we can have the credentials built in, stored. I think a lot more POCs, experimentation can be done with that. And the third area, I think, is this whole area of data anonymization. All government programs are collecting large amounts of data, right? And obviously many of them will have personally PII information, right? And so today, again, we are not doing enough to unlock that data. All that data is in there, but unless there's confidence in data anonymization for large scale systems and ways that you can't reverse engineer that and go back to the person, unless this confidence that you have really good anonymization, and of course the frameworks have to be built in, policies, government has to accept that. But I think if that's another area that's really important, because otherwise we're not doing, that data is not being used enough. There is a lot of collection happening, but using the data beyond just the immediate dashboards and reports that are used by that program, there is so much more that needs to be done for research and making it really available for different programs to start collating and then exploring that. So I think these are at least three areas where a lot more can be done.
Thank you so much, Sunita. I think very relevant things you mentioned about right from change management to data privacy, security, thinking around those and thinking first about those as I think looking into the trend stats and getting like ahead of us to mitigate and prevent a lot of these things as well. While I can go on asking you a lot of more questions to this panel group, but I had promised the audience to open the forum for asking questions, so we will get questions from our audience now. And I'm hoping that people are going to chat and we will all receive it. Okay, I'll give up maybe 20 seconds more, or I will go ahead with my other questions.
Otherwise, I can ask questions.
And no, so it will not work like that. Yeah.
Or as a prof, I would like to answer questions before they're asked.
Okay, given questions are on our way, and Sohail, you just mentioned and you started the collaboration of community here itself. So let me ask you, how do we foster this culture and have this culture of collaboration building these open source technology? What are your thoughts?
Yeah, I think, a lot of positive things have happened in the last few years. One, and thanks to the pandemic, one of the few positive things from the pandemic, the digital push is recognized by everyone. The fact that uh, it could it could help people at the time they needed that help, uh, the bridge the access issues. I think all those are positives. But at the same time, what has also happened is that it has made organizations, for profit, not for profit, government, all realize that we need to work together. And I think that's probably the other element which will foster more and more collaboration and sharing. And just to take a few examples, right? Professor Ganesh mentioned about various initiatives going on at their end to help accelerate adoption by improving certain things that could work in a low resource setting, right? Whether it's OCR or when we talk about speech to text to get the adoption going up from a doctor perspective. Again, organizations coming together and working, and we all know, right? Even large uh, corporations, whether it's Google, Microsoft, everybody's wanting to do something and also wanting to share some part of it. It's not about just monetizing everything. There are parts of that which they are very happy to share with the larger communities, and that's a clear plus for me. The other thing which I would just highlight is, uh, when we talk about various elements of templatization, and I think Sunita shared the learning of going through the sandbox process, ABDM. There are hundreds of organizations right now that are going through that process. How much can we avoid that reinventing of wheel by templatizing few things, sharing the learnings that we have had? And this is not being competitive, right? I'm sure there is nothing competitive about sharing some of those things. uh, those are clear opportunities where we need to do a little more so that we can avoid that extra effort that somebody is going to make, bring the cost of compliance down for everyone. That's a clear opportunity and a very small example of what I'm referring to. And globally, if you look at it, even Google, I don't know how many people in the audience or in the panel are aware, but there are Android Fire development kits that have been released. Collaborating with WHO and many other organizations, they're releasing open source tools for the developer community, looking at a trust architecture, issues like privacy being taken care of. We need to really leverage that. The only issue I think is the information asymmetry. We need to do a little better job on ensuring that all this is made available and is well informed to the larger communities that are working on it. It tends to be in isolated form, and that information asymmetry can be addressed.
Thank you, Sohail. So we have one question over here. How do we ensure data privacy in an open source ecosystem? Any thoughts from the group here?
I think Suhail already alluded to that. There are several best practices. Um, they just need to be made open, and somehow the notion of open source is unfortunately associated with lack of privacy. I think that's unfortunate. I mean, both security, privacy, they need to the culture needs to be built into open source as well, and that's only possible when people share, right? There's no fun in keeping my algorithm for encryption to myself when 10 others could have benefited from it, because that's not where we should be competing, right? We should be competing to make things more efficient and not just reinventing the wheel. I think this is an overall mindset that we need to address. I mean, I'll take this liberty to also bring in this mindset issue. More about the culture of open source among students. May I, Ruchika? So this is important,
Sure,
I
sure.
believe. I mean,
Absolutely.
the culture of open source among students is really required. They need to graduate beyond being consumers to producers of technology. I mean, unfortunately, I spoke many nice things that are happening, but this is still a pain point. Students today in engineering colleges are being trained largely to be, consumers of technology. I mean, an engineering student is a consumer of technology. Why do I say that? Well, they would probably get to assemble different embedded systems, but the chips are made available to them. So the whole culture is what I look for, what's there in the market, and try and assemble things. But open sourcing requires little more than that. You need to critique the components that you get. I think this goes deeper into even our education system itself, where children should learn how to assemble bicycles from nothing, right? So this is very important, I would say, to bring this culture in. Now, one way to handle this, at least at the level of colleges, is maybe students should be just doing more internships at companies that produce software. I would like to distinguish, software as solution, software as a product, and software as a service, right? Now, when you have a software as a product, you might really want to just sell it, make money. There may be IP issues associated, but especially when it comes to software as a solution, there's so much scope for making that open source. And I would like to again, give credit to ThoughtWorks for doing that with Bamni, which actually has raised the low hopes, right, for widespread adoption of ABDM. But now the same solution can lead to, there can be business models around that solution. So along with the creativity on the software front and making it open source, students can be creative about market innovation there. So that the software as a solution brings in that aspect, right? And then of course there could be a software as a service. A lot of machine learning components could be software as service. So I think this culture needs to be addressed very deeply. Open sourcing, bringing rigor in there, and becoming producers rather than consumers. Yeah.
Thank you. Thank you so much, Professor Ganesh. And there is another question. What is the future of open source technology in the diverse Indian healthcare scenario? I think it's emerging, it's growing. At least for Bamni, I can say it is the first source software which is ABDM compliant as well, received certification for all the milestones here. But I can open this question for others to respond here. Any thoughts? How is the future?
No, I think you're right. I mean, I think that's definitely the direction that we're all moving in. And, even the METI, for instance, policy does mandate at least that most of the government programs, the preferred should be go with open source software. So I think that's certainly the direction that we're going in. And, with ABDM now, there'll be a more of a impetus towards, sharing on these platforms. So, yeah.
Thank you, Ms. Sunita.
I would like to add that India also has this late mover advantage in this digital health sector. So because we have late mover advantage, we can probably learn from all the mistakes committed elsewhere. And I certainly feel open sourcing is will be one of the best lessons we can learn, with the caveats that several of us have talked about earlier, right? Security, privacy, and rigor, and so on. So, I mean, there have been lots of success stories as well, and if the why part can be made advertised a bit more, right? The fact that open source gives healthcare organizations more complete control over the IT infrastructure, they can upkeep it, people can contribute. The why part becoming more advertised would also ensure there's greater buy-in.
Thank you so much. I think very insightful and relevant discussion. Garima, over to you.
Yes, thank you. Thank you so much to all the panelists. Yes, as Ruchika rightly said, very pointed insights shared today on the various aspects of, can open source technology be the solution to accelerated digital healthcare in India? So we would like to inform the esteemed gathering here, about two of our upcoming events. The 4th Diagnostic Leadership Summit on the 22nd and the 23rd of March this year, and the 2nd Pharma Leadership Summit on the 26th and the 27th of April. In this year as well. I once again extend a very warm gratitude to all our esteemed panelists here for their time and presence. So please accept a small token of gratitude from our end to these certificates that we present to Ms. Sunita Nadumuni for your time and your very valuable insights, ma'am. Thank you. Mr. Suhail Bidani, Lead Digital Bill and Melinda Gates Foundation. Thank you so much, sir, for your presence at our summit. Dr. Manju Sengar, Professor Medical Oncology at Tata Memorial Hospital. Thank you so much, ma'am. Professor Ganesh Ramakrishnan, thank you so much, sir. It was a delight listening to your deep insights. And Ms. Ruchika Bhargava for wonderfully moderating this session and allowing us to delve deeper into this topic. And of course, our heartfelt gratitude to Dr. Praveen Gedam, Additional CEO NHA, for his message for the panel and the summit. So thank you so much all for your time and your presence here. Thank you so much.
Thank you. Thank you, everyone.
Thank you. Bye-bye.
Thank you.